lateral vein. Yes, congratulations to, where is Padma?
Yeah,
Yeah, you are here. Dr. Sanjay received Padma Shri. Dr. Sanjay received Padma Shri way back. So let us congratulate Dr. Sanjay. And I wish Padma Shri sooner or later receives Padma Vibhushan. So, Anuji, thank you very much. My SIC, Sunita Bhadra has come. Sunita ji, welcome. AK Singh Saab, we always remember you. PK Saab always remember you. Whenever we sit together, he always takes our name. Satyagwal sir. So let us discuss treatment of nephrotic syndrome in 2025. As everywhere, there are few syndromes in nephrology. The whole of the nephrology can be divided into 4 syndromes. These 8 syndromes: nephrotic syndrome, nephritic syndrome, AKI, CKD, asymptomatic immunovoltage, hypertension, hematuria, and RPGM. There are only 4 conditions. There are, out of these 8 conditions, only 4 conditions where serum creatinine rise or there is renal failure. That is AKI, acute kidney injury, CKD, chronic kidney disease, nephritic syndrome, and RPGM. If any patient of yours comes with this raised serum creatinine or raised urea, that is decreased kidney functions, this patient will fit into any one of the 4 syndromes. AKI is reversible if treated well in time. Nephritic syndrome treated well in time, reversible. RPGM, 50 to 60% patients, if identified well in time, they are reversible. And the ultimate goal, ultimate fatality of all these syndromes is CKD. So the responsibility of EC and every nephrologist is prevention of every patient going into CKD, chronic kidney disease. Because once the patient reaches to chronic kidney disease, the things become reversible, and from that point onward, there is relentless progression, and ultimately patient goes to end-stage renal disease. Once the patient reaches to end-stage renal disease, only treatment that left is renal replacement therapy, either in the form of maintenance hemodialysis, CAPD, continuous ambulatory peritoneal dialysis, and renal transplantation. So our job is, physician's job, nephrologist's job is to as much prevention as possible to stop the progression of kidney disease so the patient does not reach to chronic kidney disease. So, nephrotic syndrome. The definitions of nephrotic syndrome: the heavy proteinuria more than in adult 3.5 more than 3.5 gram per day, hypoalbuminemia, hypercholesterolemia, and edema. My talk is basically focused for the treatment of nephrotic syndrome because this is the prototype of nephrotic syndrome from age 1 to 18 year. Here there is little difference in definition of nephrotic syndrome. Nephrotic range proteinuria is 24-hour urinary protein creatinine ratio. Protein creatinine ratio actually measured in a spot urine sample, and this is almost comparable with the 24-hour urine protein excretion or measurement. So nephrotic range proteinuria, we call it when this is 2 gram per gram. Nephrotic syndrome when this heavy proteinuria combines with low albumin or edema when the serum albumin level is not available. Now depistic findings, they are the depistic findings of proteinuria. Negative is 0 to 15 milligram per deciliter, trace 15 to 30, plus 130 to 100 milligram, and plus 200 to 300, and plus 3 means there's a severe heavy proteinuria to the tune of 300 to 1000, and plus 4 means more than or equal to 1000 milligram per deciliter. This would be the reflection. Now, what do you mean by remission? Remission means that when the patient is treated or not treated, the proteinuria disappears. Now this is called complete remission. The 24-hour urinary protein creatinine excretion is less than 0.2. It becomes almost absent, or on depistic finding this becomes trace or negative. This is called complete remission. Partial remission, when the proteinuria does not disappear completely, it's between 0.2 to 0.2 to 2, then this is called partial remission. This has got relevance, I'll talk to you later. Relapse, where you will call your patient, that patient he or she has relapsed when patient develops more than 3 dipstick for 3 consecutive days, this means that your patient has relapsed. Now, steroid-sensitive nephrotic syndrome are those patients who respond to steroid, 4 weeks of steroid therapy. They are steroid-sensitive nephrotic syndrome. Children, almost 90%, 99% patient, they are responsive to steroid. And since they are responsive to this steroid, in children less than 12 years, kidney biopsy is not done. Because almost 99% patients, they belong to minimal chain disease, and they are all, most of them are steroid responsive. So biopsy is not needed in a child less than 12, the child of 1 to 12 years of nephrotic syndrome. Now, infrequent relapse. When the patient or child develops less than 2 relapse per 6 months or less than 4 relapse in 12 months, this is called, these patients are called infrequent relapse. Frequent relapsers are those patients who develop equal to or more than 2 relapse in 6 months or equal to or more than 4 relapse in 12 months. Steroid dependent, obviously as the name indicates, steroid dependent means patient is dependent on steroid therapy. It means the patient develops relapse during the full therapy or during tapering or within 15 days of stopping treatment. Then these patients will be labeled as steroid-dependent nephrotic syndrome. Steroid-resistant nephrotic syndrome, this is a challenge. Almost 4 to 5% patients, children, they develop steroid resistance. And steroid resistance we call when the patient does not respond to steroid with a complete adequate 4 weeks therapy. Then we label these patients as steroid-resistant nephrotic syndrome. And late responders are those patients who respond partially till 4 weeks and they respond completely after 6 weeks of steroid therapy. These patients are called late responder. And next is CNI responder, responsive SRNS. CNI means calcineurin inhibitors. Namaste ma'am. Calcineurin inhibitors. Calcineurin, for example, cyclosporine and tacrolimus. There are 2 drugs, they are calcineurin inhibitors. And steroid-resistant nephrotic syndrome, calcineurin inhibitors are given. And 50% of steroid-resistant nephrotic syndrome, they respond to, or sometimes they respond to completely or sometimes partially to the cyclosporine and tacrolimus. CNI-resistant nephrotic syndrome, CNI-resistant steroid-resistant nephrotic syndrome. Few patients, 1 to 2%, to the tune of 1 to 2% of steroid-resistant nephrotic syndrome, they do not respond to cyclosporine and tacrolimus. This group is called CNI-resistant steroid-resistant nephrotic syndrome. Now, next is multi-drug resistant nephrotic syndrome. Very reality, to the tune of 1% approximately, children, they develop multi-drug resistant, means they are not responsive to non-steroid or steroid-sparing agents. They have not responded to cyclosporine, cyclophosphamide at the full dose or adequate duration of the therapy. Then they are called multi-drug resistant nephrotic syndrome. Next is secondary steroid-resistant nephrotic syndrome. These patients belong to those group who are initially they are responsive, but later on the course of the disease they become steroid resistant. They are called secondary steroid-resistant nephrotic syndrome. Approximately 0.5% MCD children, they have steroid resistance. Now management. Basically management is grouped into 2 things. One is general management and one other is specific treatment. General management, simple, short restriction to the tune of sodium less than 2 grams per day, diuretics, loop diuretics, sometimes combined with potassium sparing diuretics, anticoagulants. If the patient has severely nephrotic syndrome, severe hypovolemia less than 2 grams per day, these patients are prone to complication, thromboembolic complication. So thrombosis can develop in any vessels of the body, cerebral, renal, anywhere this can develop. So these patients are put on anticoagulant prophylactic therapy till the patients go into remission. And the warfarin is a drug of choice. Calcium and vitamin D supplementation. Calcium and vitamin D patients, they have to be really on steroid for longer time. So they go into negative calcium balance, bone mass decrease. So they have to be supplemented with calcium and vitamin D. This is very important. Gastroprotection with ranitidine or PPI, since patients are on steroid. So there are recommendations. Patients should be given PPI or ranitidine. 6 is RASI and ARB, renin-angiotensin inhibitors and ARB. In here, one point is important. In acute nephrotic syndrome, ACE inhibitors ARB are not given because if you give, there are chances of going into precipitation of acute kidney injury. So RASI and ARB, they are given in those patients who are steroid resistant patients because we don't have therapy, because we don't have any left therapy. They are not responsive to steroid, they are not responsive to calcineurin inhibitors. In this group of patients, the conservative therapy, RAS, angiotensin inhibitors and ARBs. Ultimately, these patients go into renal failure and ultimately they require renal transplantation. Now, treatment. Oral steroids. This is a standard drug. This is a very important discovery, use of steroid in nephrotic syndrome, because before the discovery of nephrotic syndrome and use of nephrotic syndrome, prednisone and steroid nephrotic syndrome, the mortality rate was very, very high. Almost 50, 60, 70% patients used to die, but the steroid has produced miracle. From 1970, since when the protocols have been developed for the treatment of nephrotic syndrome with steroid, there are dramatic change in morbidity and mortality. So dose of steroid is 60 mg per meter square or 2 mg per kilogram per day for 4 to 6 weeks daily, followed by 40 mg per meter square or 1.5 mg alternately for 4 to 6 weeks. This depends upon you. You can use it for 4 weeks, you can use it for 6 weeks. Longer the duration, better the chances of less relapse. Oral cyclophosphamide. This drug is given when the patient is frequent relapse or steroid dependent, and the dose is 2 mg per kg for 12. This is given 12 weeks, and cumulative dose should not exceed. This is lifetime cumulative dose should not exceed 160 mg per kilogram. So this is given once in lifetime. Cyclophosphamide is a very good drug. It should be given once in lifetime, 12-week course, because of danger of gonadal toxicity. We have to monitor weekly CBC because of chances of bone marrow depression, gonadal toxicity. Because of danger of gonadal toxicity, this drug is given once in lifetime. And bladder toxicity, bladder cystitis, hemorrhagic cystitis, sometimes patient develop. So you have to maintain the diuresis while you are giving cyclophosphamide. Oral levamisole is again very good drug, given in the dose of 2.5 mg per kilogram per day, maximum of 150 mg. This is to be given for 12 months. And the basic fundamental of medicine is we should not do any harm to the patient. So always, whenever you prescribe any drug, you always watch for their side effect by monitoring CBC and SGPT, SGOT, ANCA. And once the patient develops rashes or agranulocytes, you stop this drug. Mycophenolate mofetil is again given for frequent relapse and steroid dependent. The dose is 1200 mg per meter square per day in 2 doses. This should be given for 12 months. Mycophenolate sodium, the equivalent dose of mycophenolate mofetil and sodium is 500 mycophenolate mofetil equivalent to 360 mg. Mycophenolate sodium, they have equal efficacy, but this is given when the patient is intolerant to mycophenolate mofetil, because sometimes mycophenolate mofetil causes abdominal pain. In those conditions, mycophenolate sodium can be substituted, and the equivalent dose is 500 360 mg. Rituximab, this is given 375 mg per meter square IV, 1 to 4 doses. Watch for this is to be monitored by, this is an anti-CD20 antibody, monoclonal antibody, and you have to monitor CD20 levels. Before giving rituximab, you should be careful for excluding hepatitis B. You must do hepatitis surface antigen test, quantiferon, furon, tuberculosis to exclude tuberculosis, and you should monitor Ig level because this reduces immunoglobulin production. So before giving rituximab and after giving rituximab, you have to monitor IgG level. If the IgG levels are low, you have to give IgG level to prevent serious infections. Calcineurin inhibitors, there are 2 drugs available in this, cyclosporine and tacrolimus. Cyclosporine is a very good drug, 4 to 5 mg per kilogram per day, 2 doses. And this should be monitored by this blood level. And the blood level recommended is 12-hour trough level is 60 to 150. And toxicity, well, you have to be careful about its toxicity, and toxicity are hypertrichosis, gingival hyperplasia, and nephrotoxicity. Usually patients who are given cyclosporine for 2 to 3 years, usually the biopsy has been prescribed, recommended to watch for development of renal toxicity. If there is evidence of renal toxicity in biopsy, then we should stop cyclosporine. Tacrolimus dose is 0.1 mg per kg. Target trough level is 5 to 10 nanogram, and the common side effect is diarrhea. Now, treatment of nephrotic syndrome. We have discussed so far drugs available. 5 or 6 drugs are available. 5 or 6 drugs are available in our armamentarium. Now we'll discuss the treatment of nephrotic syndrome. So, treatment of steroid-sensitive nephrotic syndrome. First episode patient comes to you. You should go full dose of steroid. That is prednisolone 60 mg, 4 to 6 weeks, followed by 40 mg alternate day for 4 to 6 weeks. That is 8 to 12 week course of corticosteroid therapy. This is an adequate steroid therapy, and every child should receive initially. Now, though there are group of patients, there are nephrotic child patient, 80 to almost 99% patient respond to steroid, and out of these responsive steroid in nephrotic patient, 80 to 90% patient they relapse. Out of these 80 to 90%, 30% patient they remain, 20% patient they remain in remission, and 50% goes into an infrequent relapser, and 50% patient they steroid dependent, or sometimes 4% patient they become steroid resistant. Now, treatment of frequent relapsers. Now, patient comes with their relapse. Now, there is different dose. Who have prednisolone for 60 mg till proteinuria negative for 3 consecutive days. पहले एपिसोड में हमने दिया था 4 हफ्ते तक. अब यहाँ पर हम दे रहे हैं जैसे ही प्रोटीनुरिया 3 दिन लगातार खत्म हो जाए, we come to the alternate day therapy, that is 40 mg again 4 to 6 weeks. आगे भी रिलैप्स अगर होते रहेंगे तो इनको रिलैप्स को जब तक पेशेंट को स्टेरॉइड टॉक्सिसिटी नहीं आए, आप स्टेरॉइड देते रहिए, कोई प्रॉब्लम नहीं. अगर स्टेरॉइड टॉक्सिसिटी आएगी तो फिर हमारे पास स्टेरॉइड स्पेयरिंग मेडिसिन है, उसको हम इस्तेमाल करेंगे. एंड नाउ frequent relapsers, those frequent relapser patients who develop steroid toxicity. Steroid toxicity in the form of linear growth कम हो रही है, weight बढ़ रहा है, moon face आ रहे हैं, infections हो रहे हैं, bone mass कम हो रहा है, and thrombotic infectious complications हो रहे हैं. These are the patients who are to be put on steroid sparing agents, and these are the 6 steroid sparing agents available with us. Cyclophosphamide dose we have discussed 2 mg per kg, levamisole 2.5 g alternate day, mycophenolate mofetil 1200 mg per meter square, rituximab 375, cyclosporine 425, and tacrolimus 0.1. The cyclophosphamide given for 12 weeks. Rest all drugs they are given for 1 to 2 years continuously, but watch for their side effects. Now, treatment of steroid dependence. Steroid dependent are those patients who are given steroid. Once you take the steroid, once you take off the steroid, they relapse. So obviously these patients are more prone to steroid toxicity. So naturally these patients are to be put on steroid sparing agents. And steroid dependent patients are can be treated by 5 drugs. And the use of drugs, which drug would you use? This depends upon the available resources, financial condition. Almost efficacy wise they are almost similar, but depends upon which drug would you use. That depend upon, as I've said, available resources, working local conditions of the patient. And the dependent patients are given cyclophosphamide 12 weeks, mycophenolate 1 year, rituximab 1 to 4 doses. So of rituximab given, cyclosporine for 1 to 2 years, tacrolimus and for 1 to 2 years. And basically, as I have already said, the treatment of nephrotic syndrome is academic, but this is also this is also involves some art of treatment. Suppose patient of steroid dependent patient, you have produced a remission by steroid, put the patient cyclosporine. Cyclosporine is given to more than 2 to 3 years, can go nephrotoxicity. After 2 years, you can switch the patient on mycophenolate. And the dictum is, as the minimal change patient child age progresses, the disease automatically disappears. Almost steroid sensitive patients, which are 90% to the tune of 95%, whether be they are frequent relapse or be they are steroid dependent, they usually do not go to the renal failure, and ultimately as the age advances, disease disappear. So these are the drugs available for steroid dependent nephrotic syndrome. Now, treatment of steroid resistant nephrotic syndrome. This is a difficult scenario. 4 to 5% patients, they develop steroid resistance, and the cause of steroid resistance one should look for. Maybe patient needs maybe too much edemators, so that steroid absorption from the bowel is decreased. Patient might be having some occult infection that might be causing some steroid resistance. So look for correctable cause of steroid resistance, and then you need to do biopsy. Biopsy, you may get other disease other than the minimal change disease. Even then, 50% of the steroid resistant patients are steroid minimal change, and rest may be focal segmental glomerulosclerosis or mesengoproliferative glomerulonephritis. If you find focal segmental glomerulosclerosis on biopsy, then steroid can be continued for 4 to 5 months. So the treatment of steroid resistant nephrotic syndrome, again calcineurin inhibitors, and you can use IV methylprednisolone 500 mg per meter square for 3 days prior to starting CNI. And as we have discussed, after completing a CNI therapy, you can put the patient on IMAB. So basically, this here also involves your skill, your art of managing the patient, your patience, because here doctor patience is tested very much. So you have to be very careful, you have to be very patient, and especially those patient is answers, family answers, but doctors should be very, very patient and very knowledgeable, so that you can communicate everything to the patient, everything to the patient attendant, so that they also understand the basic problem of this thing. In a certain group, those steroid resistant, if a patient is not responding to any drug like cyclophosphamide is not given a steroid resistant CNI, then there are chances, 50%, 40% chances, the rituximab injection can produce remission. And there are some drugs, those resistant patients who are CNI resistant also, there are some trial undergoing sparsentan. Sparsentan is a drug which is ARB blocker and endothelin, dual blocker, endothelin and ARB blocker, and LDL lipid apheresis. And by giving LDL lipid apheresis, 20-30% steroid resistant nephrotic syndrome, they may go into remission. Now, biopsy in nephrotic children. When would you do biopsy in nephrotic syndrome child? Obviously, when the course is not typical, then you would like to do the biopsy, because by biopsy you will know the exact pathology, and followed by then you can plan the treatment, or you can prognosticate the patient. So when the child presents with nephrotic syndrome at 20 years more than age, steroid resistant nephrotic syndrome, secondary steroid resistant nephrotic syndrome, and the nephrotic patient developing acute kidney injury, and this acute kidney injury not because of hypoalbuminemia or hypovolemia. Many nephrotic syndrome patients who have a very severe low level of albumin, they develop acute kidney injury. This is most of the time pre-renal or acute tubular necrosis. Once you give albumin and the effect of steroid comes, this kidney function recovers. So the point is, acute kidney injury not due to hypovolemia. This is very important. Then you need to do biopsy. Hematuria patient has atypical presentation, hematuria, low C3, ANCA positive, patient on CNI, patient who has developed, patient is receiving tacrolimus on cyclosporine for 2 to 3 years. The biopsy is done to identify the cyclosporine toxicity. And there are some nephrotic syndromic features. That is not classical nephrotic syndrome, but the syndromic feature means neurodevelopment, patient who has got neurodevelopment anomaly, facial dysmorphia, ocular abnormality, deafness. These patients need to be biopsied, because these patients usually have focal segmental glomerulosclerosis because of genetic diseases, and their treatment is always conservative, and they always go to renal failure and they need transplantation. So this is all in management of nephrotic syndrome. Thank you. I will respect it in the time.
Thank Dr. Sengar sir for delivering such a wonderful talk. the session is open.
Yeah.
Now this session is open for discussion.
Yes.
Any questions from audience?
आगे रख दो बेटा।
हाँ ये बड़ा कॉन्फ्रेंस वाला स्टाइल बड़ा है।
First of all, thank you very much, Professor Sengar sir, for such a nice talk. As a physician, it's a basic question which I am asking because most of the physicians they treat up to the level of prednisolone only, and after that most of the patients when they don't respond they are referred to you only. So can we replace the prednisolone with the deflazacort which is being used nowadays for the other diseases as a substitute for the prednisolone because the side effects they are less?
Definitely, side effect with deflazacort is less, but trials are with prednisolone and prednisone. Trials are not with deflazacort, but I have used deflazacort in few patients because of side effect problem. But recommendations are when you develop side effect, you use steroid sparing agent rather than deflazacort.
I want to know one question, sir.
Sir,
How common is nephrotic syndrome in adult chronic renal failure?
how common is nephrotic syndrome?
In adult population, as a renal failure, chronic renal failure.
Okay.
Sir, same question is from my side also. My query is, sir, usually when we found nephrotic syndrome patient, usually it's adult cases, we start steroid first and then see that this steroid is responsive or not. My question is that when we should do renal biopsy in these cases, whether we first do a renal biopsy, then start these drugs all after renal biopsy we...
Okay. Previously there was recommendation all adult nephrotic syndrome should be biopsy, but since when, and one of the most common cause of nephrotic syndrome in adult is membranous nephropathy. Since when the immunological tests available, blood sample available, immunological tests are available for diagnosis of membranous nephropathy, that is anti-PLA2R antibody. So any adult patient who present with nephrotic syndrome first do anti-PLA2R antibody. If this is positive, means this patient is suffering from membranous nephropathy, no need to do biopsy. If there is PLA2R antibody positive, this is membranous nephropathy, and treat membranous nephropathy. And treatment for membranous nephropathy protocols are there. One is Ponticelli regime, another is rituximab. So two drugs are available, Ponticelli and rituximab. Otherwise, if you don't have PLA2R antibody, all adult nephrotic syndrome should be biopsy. You may find various causes of nephrotic syndrome in adult, primary and secondary. Primary are focal segmental glomerulosclerosis, membranous nephropathy, meningoproliferative IgA nephropathy, renal amyloidosis, and diabetes. Secondary may diabetic nephropathy, lupus, and other disorders. So all adult nephrotic syndrome biopsy, but you can do PLA2R antibody.
Sir, I have a question.
Sir.
PLA2R antibody.
Recommendations are PLA2R therapy with a rituximab therapy or Ponticelli regime should be monitored with PLA2R antibody. बायोप्सी जरूरत नहीं है. आप बायोप्सी
मतलब स्टार्टिंग में मतलब केवल एंटीबॉडी के लेवल पे हम रिटॉक्सिन दे सकते हैं.
अगर मिनिमल चेन के साथ सॉरी मेम्ब्रेनस PLA2R के साथ पॉजिटिव के साथ अगर रीनल फंक्शन डिरेंज हैं then you need to do biopsy to for prognostication purpose.
Sir, I have a question, sir.
Yes.
Sir, how do we manage edema in patients with nephrotic syndrome,
Okay.
so that they don't land in complications?
Right. One first important thing is salt restriction. Number one, diuretic, loop diuretic combined with a potassium sparing diuretic. If the serum albumin is normal, patient 100% will respond to it. If serum albumins are low, patient will not respond to it or partially respond to it, and then you can add albumin. Dose is periodic dose is 0.5 to 1 gram albumin per day.
Sir, I want to correct in this thing. In nephrotic syndrome, by definition, it is 3.5 grams per meter square. अगर आप एल्ब्यूमिन दे रहे हैं तो 20 grams of albumin will be out within 5 days. So albumin should be given only in 3 conditions in nephrotic syndrome. If patient is hemodynamically unstable, or if patient is having any other comorbidity, then only albumin should be given. Otherwise, it will be waste. After 5 days, you will be on square A.
बिल्कुल सही बात है। पेशेंट है, अगर पेशेंट सिंपल कूल पेशेंट है तो जरूरत नहीं देने के लिए। अगर एटिपिकल प्रेजेंस आपको डायबिटीज नहीं हो रही है, वजन बढ़ रहा है, साइटिस आ रही है, एसबीपी हो रही है, थ्रोम्बोएम्बोलिक के चांसेस ज़्यादा है, एक ही आई डेवलप हो रही है, देन यू नीड टू गिव एल्बुमिन अलोंग विद डायबिटिक।
सर
काजी साहब, हाँ
सर, मेरी सवाल पूछने की ज़रूरत तो नहीं है आपसे।
बिल्कुल सवाल है
वो मैं अभी भी आफ्टर लॉन्ग 24 ईयर आई रिमेंबर माई war date.
You still look young.
Yeah. Sir, believe me, and I'm in mood here to learn something from you. Really, that's why I'm asking you a question. Sir, dealing daily practice cardially, CCS, ACS, and so many things. Sir, and I have seen in adult patient more development of this CCS and ACS feature in nephrotic syndrome patients. I'm managing my part and nephrologist their part. Believe me, I'm managing my parts only. So, giving statin, antiplatelet dual and sometimes NOAC also, I'm not using VK usually. So, I mean, can you suggest something more to save my patient to reduce their hypercoagulable state, what you was teaching? You asked me that question on that time, I remember it.
Hypercoagulability will reduce once the patient goes into remission.
And atherosclerotic process, can you teach something more that I can stop atherosclerotic process in nephrotic syndrome to lend up further into CCS?
Yes. So, in children, these acute nephrotic syndrome patient, hyperlipidemia or atherosclerosis is not a big problem. Once the patient goes into remission, this problem disappears. But those patients who do not respond, especially adult patients who do not respond to or partially respond to immunosuppression, and they're continuously pouring this thing proteinuria, they need to give statin because of the hyperlipidemia, and which since they will not go into remission, they need to be on statin or ASVD prevention strategies.
Which statin you like, Atorva or Rosu?
Both.
What is your cutoff level for?
So thank.
Atorvastatin, there is no cutoff value.
Yeah, for Rosua.
Rosuvastatin. Rosuvastatin, I don't know, some cardiologists may comment, but atorvastatin dose is not reduced. Even ESRD patient, if you need to give 80 milligram, you can give 80 milligram.
Thank you, Dr. Sengar, for such a very wonderful, great conversation. We now conclude this session, and I request all speakers to chairperson to please present the memento to Professor.
Sir, आप भी आइए. Yes.
And I request Dr. Sengar to please present the memento
Yes, sir, यहाँ पे देखना.
chairperson.
Thank you.
Please get it. Yeah.
Yes, sir. Thank you.
नाम लिखा हुआ.
So meanwhile, I would request the chairperson to occupy their seats for the next session on interesting cases in neurology from spotters to heredity by Dr. Kadam Rajpal, Dr. Pradeep Jain, Dr. D.S. Gupta, Dr. Arvind Kankane, Dr. Kuldeep Chandel, Dr. Sunaina Sood and Dr.